My name is Gail, and I work for PICC Fusion. We've come here for several years, I know, and I've been here. I live in Muncie, so I'm a little out of the. You might get some indie girls, but whoever's able to come in the shortest period of time, we come. I've been a nurse for almost 30 years, worked in a hospital in Muncie for 25, worked in ER for 20, and learned how to place PICC lines about 5 years ago. So this is all I have to do anymore. But I know that when you guys deal with PICC lines, it's a small piece of what you have to do. So I'd like to give you a little simple information so that you don't have to spend much time worrying about your PICC line. When we come and place it, we're going to have it checked with an x-ray. We're going to put a sterile dressing on it, and then it's up to you, okay? So we're just going to go through what a central line is. You also get other central lines, and basically they all need to be maintained the same way. Any central line is going to have the tip end up in the SVC, the big vein here above the heart, and they're going to have a chest x-ray. There are some machines now that will give an EKG confirmation of the PICC. Most of us don't travel with one yet, but it can be confirmed in a little EKG paper is printed off that shows where the end of the PICC has triggered the device and has enlarged the P wave. But as long as we're putting them here, we won't do that. We'll do the chest x-ray. Doctors insert them into the jugular vein or into the chest. And then inserted port is also a central line that's been permanently put under the skin. So the tip must be central. We put it in the SVC, or the cable atrial junction, which is the junction right above the heart. It's kind of subjective, so we wait for the radiologist to confirm it. And sometimes if they say it's in the atrium, then we just have to pull it back a little bit, okay, to make it considered confirmed. And we put a lot of things into the vascular system anymore, so we know that we have to do it carefully so that we save people's vessels. We need them until we're done. So, and central lines then are used for chemo. We give strong antibiotics, any antibiotics. They can be used for any pain medicines, anything in the hospital setting. And we give blood through them, we can hydrate, we can give TPN through them, and then what is really handy is that we can draw blood from them. And it saves people a lot of sticks. And I was talking to somebody I think it was Tasha, as we've blown everybody's veins, these are becoming more and more not only popular with the patients, but with nurses, because it takes so much time to draw your own blood. So if one's put in the jugular, it is run down the jugular vein into the SVC. A subclavian one's inserted on either side of the chest and run into the SVC. We choose one of these three veins and travel it up and down into the SVC. PICCs are only inserted into the arm, and I can't do a jugular, so far. As doctors still have to do them. They are training, I know, some nurses someplace. We have non-tunnel catheters, which are the ones that are put directly into the vessel, here in the neck or chest, or into the femoral. Tunnel catheters, usually the Hickmans are usually used for dialysis. And they're tunneled underneath the skin and then into the vessel, trying to maintain more sterility by keeping the insertion site away from where it accesses the vessel. Your implanted ports, and then the PICC lines. PICC lines, other than implanted ports, have the least risk of infection. They probably have a little bit higher risk of blood clots, though, because they travel in a longer vein. So we have to be concerned about that. The three things that once you have a PICC line in, you want to be concerned about is infection. It can be either at the site or systemic. Blood clots in the arm, which usually shows up as a swelling in the lower part of the arm from the occlusion of the vessel. And then the third thing is that we don't want the catheter to get occluded. They can clog up. So that's what we're going to work to maintain. When I see a catheter like this in the jugular, they are very, very hard to keep covered. So they're very high risk. They're usually put in emergently by a doctor, and then they want them only in for about a week because they have a high risk of infection. Same way with the subclavian. Sometimes, well, this is a tunneled one, so this is considered long-term, where they've gone in and then tunneled up and dropped it into the SVC up there near the neck. And then there's your port. But mainly we're going to talk about PICC lines. I don't know if you guys ever use midlines. I insert a lot of midlines in long-term care facilities for like a long-lasting IV. On the outside they look similar. They've made them now so they'll say midline on them. And a midline just goes into the vessel about this long. It'll stop here in the axillary area. It's not a PICC line, it's not a central line. You shouldn't give TPN through it, or really vancomycin shouldn't be given through it. They're very good for someone getting 10 days of Rocephin. Or sometimes we get ladies that you just can't get an IV on, they want them to have 3 days of fluid, so we'll put a midline in.
So you say no bank?
No, not a midline. No, because it infuses right here, and bank is so, the pH is acidic, and if it inflames the vein here, sometimes you can't even tell, because someone that has maybe a fairly large circumference anyway, it could do a lot of damage. I would rather infuse bank in a peripheral if you're not putting it in a central. Okay, and this is just, you know, I mean, I've had doctors at places say a mid's fine for bank, and then I've had enough times I'd have to go replace it because of the damage it did to the vein, that now I try to encourage them to go to the central line. A peripheral, though, for bank will have to be changed probably every couple days. Same way, really, with the midline, because the vessel just doesn't get big enough up here to stop that irritation from the acidic quality of vancomycin. And then, of course, your TPN is so much thicker that you still don't want to put it anywhere but a central line. They say a midline can stay, up to 4 weeks, usually 2. When we put them in, you know, we'll sell them for 2. I've seen them stay for a long time, but they really have to keep them open because they will start to clot off. Our bodies coat these lines with a fibrin sheath, and so you'll start having trouble getting stuff through them after a while. We never use Activase in a midline, only in a central line. So if we have a midline and it's not working, we're going to replace it. We're not going to try to open it up. And you can use a midline for blood if you can get it, but it won't do it very long. So a PICC line ends up here in the SVC, a midline only ends up in the axillary vein area, depending on what vein we use. All right, so then, you know, you guys call us usually, so you are either asking the doctor for a PICC or he's deciding that you need one. Usually the criteria is that you're going to have a medicine that's harsh, you're going to have one that's thick, the osmolality of it, which is usually TPN, and then harsh is, you know, our pH is 7, so every medicine has a pH, with vancomycin being around 4. There's some, I don't know if you guys ever used IV Phenergan. It was very alkaline, and we would burn up all the veins because it was like a 10, and we'd give it IV, and if you had any repeat patients come in over and over again, you could even tell that their veins would start to get hard. And so in ER, they took it away from us. I think upstairs or on the floors they could dilute it and give it. So that's one reason we want to have, we choose a central line. Either that or you can't get an IV access. I mean, we've poked people hundreds of times, sometimes trying to get a line in, and they get quite frustrated with it. If they're getting real frequent blood products, you know, that the PICC line can save them. Sometimes they're every 6 hours, you know, and but we do not usually, we want to have the consent of a nephrologist if we're putting a PICC line in anyone that has like late stage renal disease. they want the vessels saved for your dialysis shunts. So we do call the nephrologist if somebody has a high creatinine. If they have a high creatinine and they don't have a nephrologist, then we usually put it in. So it's just one of those kind of safety guards that we have to check out when we come and check on if we're going to place a PICC line. If they do, if the nephrologist says no, then they're going to have somebody put them in the neck or something, the jugular. When we insert a PICC, we choose these vessels. The median is just the one that kind of goes across here and connects then with the basilic. But we use the ultrasound. It's usually pretty easy then to find one of these two vessels, and my machine's not dirty. It just clouds up as I travel and the weather. We numb their arm. We're going to go in there in a sterile setting, gowning and masking and gloving to put the line in. And so then we want to, after I insert it sterilely, then it has to stay sterile. So that's kind of what your job is. As I travel to some of these, especially, usually hospitals aren't bad because, nurses are familiar, but long-term care facilities, they have so many changeovers. I've seen them dressed with half of it hanging out, and so I guess it's scary knowing that, a bloodstream infection can cause a lot of trouble, so just hate to see it. So we want to maintain the sterility of it while it's being used. If it gets pulled out, it's been removed from the SVC, so it either needs to be exchanged or re-x-rayed to make sure that it hasn't been pulled out of the SVC. So we're going to get the placement, and it has to be in the SVC or the cavoatrial junction. It may have a little bruising where we insert it. It may develop a little site. Occasionally I've even had somebody have a swollen area, depending on the integrity of their blood vessels, because some people, once you put a hole in it, it will seep out then afterwards. A little pressure on that. I sometimes just will take some extra pressure on it for a short time after I put it in, but usually it will just, heal up within a day. All that will go down. Few people will bleed excessively. Some people have very high INRs, so, if they're on Coumadin. So these are things that we just consider. And I've seen them where they didn't stop bleeding for maybe a day or two. I don't got too far. Just usually some pressure will stop that bleeding. It's usually a little tender the next day. But it shouldn't hurt them. And if it does hurt them, it's probably running against the nerve there. And most people won't put up with that very long. When I insert, after hitting several nerves, you learn not to do it. You place them away. So when I'm done, if they're saying it bothers them, then I make sure that either I can follow up on it, something in case it needs to be reinserted. They shouldn't have chest pain. Sometimes the end of the PICC will just irritate the sinus node and they'll have an arrhythmia. I think it's happened twice. But when it does, they'll say, they're anxious and nervous, and some people will just go, oh, that's just how they are, but just we want to pull the PICC back a little bit. So, and I've driven back to places when we've got